Well, hello, I'm Dr. Sherman Silber, the Infertility Center of St. Louis, St. Luke's Hospital in St. Louis, Missouri, and we're doing Facebook Live, and I'm going to answer your questions. I would say that we've had a lot of questions on Facebook since the last Facebook Live, and we're going to try to answer as many of those questions as we can. And if you want to write in new questions, do so. We'll either answer it now if we have time, or we'll answer it at the next Facebook Live. So let's get started.
All right, Dr. Silber, your first question is from Carla. She asks if you perform the GIFT, G-I-F-T procedure.
So Carla's asking about the GIFT procedure. That's pretty old stuff, and here's what that is. It's where you retrieve eggs from the wife, and you mix them with sperm from the husband and put them into the fallopian tube, and don't really do direct IVF. In other words, you're not making embryos outside of the body. That was popular for a while when IVF wasn't so perfectly really refined as it is now. It had a lot of problems because you didn't know for sure if those were the good eggs or not such fertile eggs. It was hard to tell. You tried to grade them, but it wasn't really reliable. Furthermore, since you didn't know that, you wound up putting in as many as 4 eggs, and so there was a risk of triplets or even quadruplets because it was an operative procedure, actually. And so, but GIFT was allowed by the Catholic Church, even in those early days, in the late 70s and early 80s. And at this point, we realized that that was not a infallible decree. The Pope never said it was an infallible decree. It was just an opinion. And so the vast majority of Catholics are willing to do IVF because it is family building, and family building is what it's all about. And GIFT itself is really not popular anymore, though it was really good in the 80s.
All right, your next question from Vera is, why do you put women on birth control before starting the cycle?
Well, this is a great question. Patients are always a little confused when I say, well, we're going to do IVF and we'll get you pregnant, and first you have to go on birth control pills. Well, the reason is that the ovary will normally have what we call non-ovulated, mid-size, non-atretic follicles. And a simple way to put that is old eggs that haven't really developed. So if you stimulate to get some eggs so that you can retrieve for IVF, you're going to get some bad quality old eggs. So the birth control pill gets you down to baseline so that when we stimulate you and stimulate you mildly, the only thing we're really going to get are the good eggs.
Thank you. Next question from Ashley. Are blood clots a common side effect when doing IVF treatments? And are there alternative drugs or methods to continue IVF if you obtain them?
So Ashley is worried about getting blood clots, which would be a very dangerous complication as a result of either birth control pills or the hormonal stimulation of IVF. So if there's any history in the family of clots, we will get what we call a thrombophilia workup. And if you have a genetic predisposition towards getting clots when your estrogen goes up, then we will anticoagulate you during the treatment and, in fact, during the whole pregnancy. And it's pretty easy to do, so we can make it successful. But if your thrombophilia workup, we call it, is negative, then the most important thing is to do mild stimulation. Now, I think most IVF cycles around the world involve very heavy stimulation with huge doses of these hormones that we found actually reduces dramatically the fertility per egg. So you get a lot of bad quality eggs, and a lot of them, and your ovaries get really big, and it's painful and uncomfortable. Your estrogen goes sky high, so there's a risk of clots, and you could even have a thing called hyperstimulation syndrome. So we avoid all that by doing our mini IVF protocol. And with this minimal stimulation, we get the same or better pregnancy rates per cycle, but we get 4 to 5 times the pregnancy rate and live baby rate per egg. So you might get 4 eggs, you might even get 10 eggs. We're not looking for 35 eggs. But those eggs that we do get will be better quality, and you don't have to go through all those complications.
Thank you. So Brittany wants to know, what are the causes for poor egg quality in a young patient?
Okay, so Brittany is asking what is the cause of poor egg quality in a young patient? Because we know that the quality of the eggs tends to go down as you go into your late 20s and early 30s and late 30s, and really terrible by the time you're in your 40s. And by quality, what we mean is not necessarily not the baby, but just the live baby rate per egg. So generally, the younger the egg, the better the egg quality. That's really clear. But there are some women who are plagued by having a lot of poor quality eggs. The only way to deal with that is when you do IVF, this Clomid mini IVF protocol, very mild elevation of FSH, an equivalent mild elevation of LH. If the LH isn't elevated just the way the FSH is and in a mild way, you don't get good egg quality. And if you're just stimulating with FSH and some drugs that have HCG but aren't really good HCG alternatives, then you're going to have just pure FSH stimulation, and you won't get good quality eggs. So sometimes you do, of course you do. But for women who are on the edge, it's really important to do what I call our Clomid mini IVF protocol, which involves just a very, very mild elevation of your FSH and your LH, triggering with Lupron, vitrifying, freezing the embryos, and then transferring them into a perfect uterine lining several months later. So that's the approach we would use with bad quality. And it's amazing, some of these terrible cases with 4 or 5 or 10 previous IVF cycles with poor quality eggs elsewhere with massive stimulation. When we just do this very mild stimulation, we get good quality eggs and we get high pregnancy rates.
It's amazing. So one of the other questions was about egg quality issue, but you sort of answered that already. So what about sperm quality? How do you figure that out?
So there's a big question about sperm quality, and there's a lot of misinformation out there about sperm quality. So you might have only maybe 5% or 2% or 1% of your sperm that look normal. And so we call that poor morphology. Or even poor motility. Maybe only 1% of your sperm have good motility. Maybe none of your sperm have good motility. Maybe they're all very sluggish and don't even swim straight forward. Certainly there's a wide spectrum of poor sperm counts or semen analysis in the male partner. But we invented back in 1992 in Brussels and first brought it, we were the first to bring to the United States in 1993, this method called ICSI, which now is very popular. And so in every single IVF cycle, we will pick up the sperm in a little pipette under 400x magnification, so it's invisible to the eye. And this pipette, where you can't see the inner diameter, it's so tiny, except under a microscope. And we will pick up the good sperm, and we'll be able to inject them. And if we only find 2 or 3 good sperm out of 100 million, it doesn't really matter, because that's what we're going to inject into the egg, and we'll get a normal fertilization rate. So it's very, very, very rare that sperm quality with modern IVF should hurt the results. But you do have to pick out the good ones.
All right, and I think staying within the realm of male fertility, can hyperspadia surgery as a child cause adult infertility problems later on?
Well, hypospadias, first let's tell the listeners and viewers what that is. That's where the child is born with a opening that doesn't come out to the penis, but is really at the base of the penis, right between the penis and the scrotum. Or it might even come out somewhere along the length of the penis. And so it's not quite normal, and they can't really urinate like boys would urinate, standing up, and they have to sit down, which women, of course, do. But it's a difficult thing, and if it's not repaired in the baby, which it normally would be repaired, then when he ejaculates as a man, the sperm isn't going to go into the vagina. I mean, the penis will go into the vagina, but the sperm will not. So hypospadias repair nowadays at pediatric hospitals. I used to do many of these when I was a young urologist, but hypospadias repair now should be successful in almost all the cases, so that he should be ejaculating out the tip of his penis rather than along the base of it. It won't have any negative effect on sperm production or spermatogenesis or sperm count. It's just an anatomical issue of getting the sperm to go directly out.
Thank you. Okay, so Jen wants to know, I've heard that there's some homeopathic options out there, such as acupuncture. How do you personally feel about these courses of action? Do you ever recommend them?
Well, okay, I may offend a lot of people on this, but I really know a lot about acupuncture. I'm a professor in China, so it's a medical school. It's a great medical school, and many people request acupuncture. I don't think it does any harm. It's fine with me if you want to do acupuncture. My opinion is that it's a good idea to be confident and relaxed and have physicians that make you, and nurses that make you feel really, really comfortable. And that has an impact on the implantation rate of the embryo because it reduces the unwanted contractions in the uterus. Now, acupuncture, if you believe in it, for sure can help you relax and feel more confident. I think the impact of it is sort of psychological. I don't think that it's really having a physical impact that's helping you get pregnant. But I also think if you want to do it, that's okay because it's not harmful. Here's what is harmful, though, when we talk about homeopathy. What is harmful is all of these nutritional supplements that the FDA has no regulatory control of, that are sold more commonly in the big drugstores, whether CVS or Walgreens or the little drugstores. The majority of their shelves are these nutritional supplements, and they make a lot of money on it, $15 billion a year industry, and the advertising is huge. I mean, these nutritional supplements can do everything. They make you live longer, they make you more virile, they make you more feminine, they're supposed to increase your fertility, they reduce heart attacks, they prevent cancer, and that's all baloney. They don't do any of that. It's complete baloney. At the end of the advertisement, they say, this has not been approved by the FDA and not designed to treat illnesses. So they can do that legally. But the risk of those nutritional supplements is often they put active things in there, and those active things can have a negative impact, like androgens or male hormones, or even what we call some pathomimetic amines. I mean, like you've always heard about the problem with phenylephrine. It can be made into meth in meth labs, so it's hard to get now. But these cold remedies, they can have a negative, they can be dangerous actually if they're not regulated in terms of the content and the dose. But certainly there's often a lot of active things put into those nutritional supplements. So I say to all my patients, avoid all nutritional supplements. Just eat a good, well-balanced diet and lots of broccoli, because broccoli has lots of folic acid in it, and the main thing you absolutely have to be sure of is you don't have a folic acid deficiency.
Thank you. Frama wants to know, can a woman with heart problems that takes medicine have IVF done?
Well, the question is, what if a woman has heart problems, like maybe she has irregular heartbeats and she's on medicine for that? Can she do IVF? Well, for that woman, for sure, the way we have to retrieve her eggs is with mini IVF, because it'll have minimal physiologic impact. I mean, it'll be completely safe for her. No problem retrieving the eggs, fertilizing them with her husband's sperm. But whether or not she should be allowed to carry a baby is a decision that her own obstetrician and cardiologist have to make. And if they tell her it's too dangerous for her to be pregnant and carry a baby, then we can put the embryos in a gestational surrogate. It'll be her baby. The laws everywhere in the United States except for New York are extremely clear on this. It's absolutely her baby. It's not the surrogate's baby. And that would be a solution. So the main thing is to get her embryos, freeze them, and then she can look for a surrogate. It could even be a friend or a family member. We can always find a surrogate through an agency, but I think it's less expensive and more desirable if she gets a friend or family member. Even her mother could carry the baby. So that would be the solution if she has a heart problem and her cardiologist doesn't want her to get pregnant.
Amazing. Somebody was asking that they had read recently about a newer no-needle IVF treatment called Coral IVF. Is that something you can talk about or even do in your office?
Well, I think that's pretty silly. I mean, everybody's looking for something more natural and less invasive, but IVF is pretty uninvasive, and you have to retrieve the eggs, and the only way you're going to retrieve the eggs successfully really is through ultrasound guidance and a needle. But to make it more tolerable and not this misery that women think about with IVF, you really need to do mini IVF because it's so easy for women to do this. It's almost like a natural cycle, and she gets up and walks away, and it's very, very simple to do. So there's no need to try to invent a gimmick. Now, in this field of IVF, unfortunately, like nutritional supplements, it can be a big moneymaker. And frankly, it's attracting doctors and business people that just want to milk it to make money and aren't really professional or honest. And so they come up with gimmicks. I don't think a gimmick is a good idea. And certainly mini IVF is not a gimmick. It's been tested and tested and tested, and the results are fantastic with peer-reviewed articles. But some of these gimmicks, though, and you can recognize a gimmick right away, the women should not waste their time with that.
So as she read about the coral IVF, is that something you heard about? I mean, like for the rest of the listeners that maybe didn't read that article, what is
well,
that?
there are many kinds of,
Okay.
yeah, I mean, there's all kinds of gimmicks like that purport to be natural and non-invasive.
All right. Many listeners or readers are curious about the statistics around IVF resulting in twins or multiples. Can you kind of explain a little bit about that?
Right. Well, multiple pregnancy is really a potential disaster. And I'm not talking about, well, it's so many kids to take care of at one time, like triplets, quadruplets, quintuplets. That's not the issue I'm talking about, but they are dangerous pregnancies. So the question, in many academic circles, the push is on for single embryo transfer so you can avoid even twins. And we'll do single embryo transfer. But the majority of American women like two embryos transferred because IVF is expensive, even mini IVF is, any IVF is expensive. And they want to maximize their pregnancy rate per transfer, not just do one at a time. Now, they could do PGS, but the genetic screening of PGS is terribly inaccurate, and you're going to wind up throwing away normal babies. And so, the idea is to try to do a single embryo transfer and have the same pregnancy rate as two embryos. Most American women actually want two embryos, and they actually are happy to have twins. In some cultures, academic cultures mostly, the emphasis is on single, and if they want a single embryo transfer, that's great. We'll be glad to do that. But most of our patients request two. We won't transfer more than two unless by ASRM guidelines they're over 40 years old, and it's considered pretty safe for a 43-year-old to transfer 3 embryos because you're just hoping you'll get one to take, and you're not going to have triplets from that. So it's up to the woman to decide what she wants to do. The thing about a twin pregnancy is it's a more difficult pregnancy, and there's a higher incidence of early birth. But frankly, in the hands of our obstetricians, and I'm not an obstetrician, I'm an infertility doctor, but in the hands of our obstetricians, twins really do great, but it's a more difficult pregnancy, and if it's early, the child will be in the hospital longer. It's more expensive to the insurance companies. They have to cover it. But if the insurance companies would cover IVF, then everybody would be happy to have a single embryo transfer. But since they don't cover IVF, most patients in America want two.
Thank you. All right, Kathleen is asking, is there anything, and I have to apologize, I don't understand the terminology, you'll have to explain a little bit. Is there anything you can do to encourage a trilaminar layer, and what are the causes of failing to have a trilaminar layer?
Okay, what she's talking about is a triple layer. When you look on an ultrasound, what you really want to see is a beautiful triple layer of what we call the endometrial lining. That means that the lining is likely to be very receptive to the embryo when we do the embryo transfer, and we diagnose that by ultrasound. Now, sometimes the absence of a triple layer is not really a problem. For example, after the progesterone goes up, and after you ovulate, you often will not see a triple layer because the lining is turning from what we would call a hypertrophic lining from estrogen to a secretory lining, which is preparing for the implantation of the embryo. And so you may lose that triple layer, and it doesn't mean anything after the progesterone. But also, if the ultrasound probe is at an angle that doesn't allow you to see it, then you may not see it just because of the angle of the ultrasound probe, and it may be therefore an artifact. But if you're sure that there isn't a good triple layer, we have a solution for that. You've probably heard of the uterine scratch, but there's a lot of misinformation all around the world about uterine scratch. Most IVF doctors say, well, we'll irritate and inflame the uterine lining so that it's more likely to allow the embryo to implant. That's not what's happening with the uterine scratch. What's happening, because we've done hysteroscopy after scratches and we know exactly what it does, it's just a simple conservative way of doing a curettage. You're actually removing a uterine lining that isn't very good, and then when you have your next uterine lining develop in your next cycle, you'll develop a brand new uterine lining. That's what we're doing. And you understand this better if I tell you that the human being is the only animal in which implantation of the embryo depends upon periodic, monthly, complete sloughing of the previous uterine lining and getting a brand new uterine lining the next month. So if that sloughing isn't quite accurate, if it isn't quite complete, if it looks irregular, then what we're doing with the scratch a month or two ahead of time is giving you a brand new uterine lining that's a good quality lining. And then suddenly, from having no triple layer, you have a triple layer, and then you're ready for implantation of the embryo.
And the same woman, Kathleen, asked a follow-on question. Also, what do you think about the new ERA test?
That's the ERA test, or ERA. So it's a similar idea, is how do we really maximize the receptivity of the uterine lining? This test has really not been documented to work by most people who are doing it. It is a financial thing. It costs a lot of money, and you take a little uterine sample and do what's called a transcriptome analysis of those cells to try to date whether or not the uterine lining is in sync with the stage of the embryo. And, it's a very nice idea to think about, but it hasn't really panned out. And it's very, very expensive. So we don't recommend the ERA test.
Jessica wants to know, do you offer Escher reversal?
Well, okay, Escher or Escher is where you put a irritative little kind of coil through the hysteroscope into the cornu, which is the junction of the fallopian tube and the uterus, and it creates a scar. So it's a non-surgical way of doing, say, a tubal sterilization, tubal ligation. So I think it's not a great idea. I did the first microsurgical tubal reversal in the United States in 1979. It was done in Canada and in England before we did, but we did the first one in the United States. So I think we're the most experienced people with tubal microsurgery in the country. And but I think for an Escher sterilization, it's better to do IVF. Because some people brought up the question whether the embryo can even implant with Escher, and it will implant. The uterus is okay. But I think to try to carve that down and suture the fallopian tube to the remains of the cornal region of the uterus is not a good idea.
Monica wants to know, is there such a thing as too much IVF? For example, she has 12 rounds. She's 12 rounds in to no avail, and she's age 43. She has below average metrics. Is it donor egg time for her?
Well, that's a good question. She's 43 years old and had 12 IVF cycles. My gosh. I don't believe it's dangerous. Some people would be afraid that all those epithelial ruptures from the needle would give you a greater risk of cancer of the ovary. I don't think so. But if she's 43 and she hasn't gotten pregnant with 13 cycles or 12 or whatever, that many cycles, yeah, I think it's time for donor eggs. So the donor egg question is an interesting one. It's very controversial, but I'm happy to give you my opinion. I'm in the business of getting older women get pregnant with their own DNA. And we have great methodology for that, and we're enthusiastic about it. So I know everybody wants their own DNA, and that's fine. We want to give that to them. But if you can't have your own DNA, let me tell you what I've observed using donor eggs since 1986, and I'm very interested in how these kids develop, because I'm interested in child development and how people become who they are. You know, how Albert became Einstein, or you might say how Albert became Pujols. How do people become what they are? And my observation is that what you care most, you can easily match for physical characteristics and appearance and racial and ethnic background. That's easy to do. But what you really care about is 5 things: personality, character, intelligence, emotional stability, and bonding with you as parent. Now, I've observed over the last 32 years that that's not in the DNA. Those 5 characteristics develop from how you bond and interact with the baby in the first 2 years of life. And so I've never had an unhappy case that needed to use donor eggs. Now, don't get me wrong. Everybody wants their own DNA. And this is a difficult bridge to cross. But if they, and that's fine, but if they can't have their donor DNA, there's no reason why you can't be happy with donor eggs.
Amazing. And so I think the final question for this evening will be something that you probably get asked a lot, but regarding cost, do you have financial programs to help people that may not think that they can afford it?
Well, yeah, certainly, like for cancer patients or people that are insurance doesn't cover preserving their fertility for all these years, we've done that for free because we don't want money to get in the way of decisions they have to make right away. For IVF, our approach is to keep it as inexpensive as possible, to use the least amount of drugs, and just to keep the cost down as much as we possibly can and have the highest success rate. Now, if you need financial assistance for it, there are methods that we'll use, but also we're not in the insurance business, but we can refer you to, there are plenty of companies that will do insurance programs and do loans for IVF, and you can do that. But we're not in the financing business. We don't want any IVF program that is in the finance business is just using it as an extra profit source, and we're not interested in making an extra profit source off you.
That's all we have for tonight.
Okay, well, so I'm Sherman Silber, Dr. Silber from the Infertility Center of St. Louis. Our website is infertile.com. And you can call us anytime for answering questions, or you can come and see us for a free consultation from anywhere in the world. And our phone number is 314-576-1400, or you can just go to the website, infertile.com, and you can get all the information in a free consultation anytime you want, because many people won't need IVF. Many people really just need some advice about intercourse and timing and how they can maximize their fertility, and we're happy to give you that advice.